يلا نبدأ.
يلا.
Good evening. Today we have another meeting. Welcome everybody. We have a meeting today with Dr. Mohsen. Will talk to us about the respiratory support for the generalist. It is a strange title, but he will explain to us. Now you can start, Dr. Mohsen.
Hello everyone and good evening. My name is Mohsen Abdelaal. I'm a specialty doctor in critical care at Lancashire Teaching Hospitals. Today I'll speak with you about the respiratory support. And as Dr. Ahmed said, it's for the generalist. It means like it's not for the doctors who are specialized in intensive care or the anesthetist. It's for everybody who works with inpatients or in ED. How to identify patients who need respiratory support and how to deliver it to them. I just want to be sure that the screen is properly shared. Can you see my screen?
Yeah, it's shared.
Right. So in the beginning, I'll just talk about the objectives of this session. By the end of this session, you should understand the basics about the respiratory physiology and be able to assess acutely ill patients and identify the patients who need respiratory and airway support, to understand the different types of respiratory failure and how to manage each of them. We'll have an idea about oxygen therapy and the different devices that you can use, and an idea about the ventilatory support, a general idea about it. It's not in details, of course. So about the physiology of our respiratory system, the main function is to deliver oxygen to the cells. And oxygen is an essential element for energy production. It's used by the mitochondria to produce ATP, and under hypoxic conditions, if ATP production is inefficient, the body has an alternate pathway, which is the anaerobic route, and this will lead to lactic acid production and lactic acidosis, and this can compromise the hemodynamics. Lack of ATP also is very dangerous to the cells because the cell will lose its integrity and followed by cellular death. So basically, oxygen is a very essential element for every living creature. For the oxygen to be delivered inside the cell, it goes through a very long journey from the atmospheric air down to the intracellular space. It goes into 6 steps. Each of them has its importance, and any defect in each of them has its different pathology. In this session, we will be mainly concentrating about the first step, which is the ventilation. So ventilation means the movement of oxygen with air from the atmosphere all the way through the airways down to the alveoli. And the next step is the oxygen will go across the alveolar capillary membrane to the blood, the process called diffusion. And then the oxygen will bind to hemoglobin in a reversible chemical bonding, which will be reversed at the level of the cell. The oxygen needs to travel from the lungs to the cells with the support of the heart. And this is the function of the cardiac output that we spoke about in the previous lecture about the management of shock. And then the oxygen will diffuse from blood to the cells. The last step is a control step, the redox state of the cell, which means each cell is determined about its own demand and has a feedback on the whole process. So if the cell has its own sufficient demand, it will suppress the whole process of oxygen delivery and the vice versa. So now we need to talk about assessing an acutely ill patient in brief. It's really important stepwise approach for everybody who is dealing with patients in ED or inpatients in general. When you have this in mind, you will have a systematic approach to any acutely ill patient, and it will put your mind in a systematic approach way. It's very unlikely that you will miss any important information if you follow this step, and it's also ordered by priority. So A is the airway. You'll assess, solve any problems you find, and then if everything is okay, we'll move to the breathing. We will talk about airway and breathing shortly, and then circulation, disability, which is like the GCS and neurological status, and then everything else like skin, rash, fever, bleeding, taking bloods, or sending cultures or whatsoever. So we'll start briefly about the airway management, because it's so linked to the respiratory support. You can't deliver any respiratory support without a patent airway. So quickly assess the airway, look, listen, and feel. Is the airway patent? Can you see any obstruction? Can you see any edema or foreign body that needs clearing? Simple way to assess the airway is speak to the patient, ask him, are you okay? If the patient answers, that means his airway is patent. And if not, if there is any noisy breathing, like stridor or gurgling of secretions, these are all signs of compromised airway. The breathing pattern as well can give you an idea if the airway is compromised, which we call the seesawing breathing pattern. Normally, in normal breathing, the chest will rise and the abdomen will rise in inhalation, and they will go down with exhalation. In an obstructed airway, when the patient tries to inhale, the chest will go down in a paradoxical movement, and the abdomen will go up. And then when he's trying to exhale, the opposite will happen, and it will give a pattern of a seesawing movement. How to manage a compromised airway? The first thing which I put in a very bright red up there is to call for help. You don't have much time if the patient is losing his airway. You have to call the RS team or the intensivist or the anesthetist on call to give you a hand about it. Meanwhile, while you are waiting for the team to arrive, just be sure that the airway is patent by simple maneuvers, or you can use airway adjuncts, which will be available in any ward in a crash cart or a cardiac arrest trolley. The maneuvers are the head tilt and chin lift. Put one of your hands on the forehead of the patient. Slowly tilt the head, extend the neck, and lift the chin with the other hand. This movement will move the tongue forward away from the posterior wall of the nasopharynx and will open the airway. If the patient has any C-spine injury, you can use the jaw thrust if you are trained to do so. And I'm sure that everybody has seen these in the ALS courses. You can use any of these devices on the picture. The one on the right lower corner is the oropharyngeal airway, the Goodell, and I'm sure that everybody knows it and how to insert it. The problem with it is if the patient is awake, wouldn't tolerate it, and it can stimulate vomiting. Or if the patient is really unconscious and clenching his teeth, it will be very challenging to insert it. So you can use the nasopharyngeal airways on the upper picture. You can use size 7 for an average male or size 6 for an average female. Simply just lubricate it with jelly, insert it from one of the nostrils all the way down, and you can use it for suction, and it can maintain the airway patent for you until the specific team arrives. Suction clearing any secretion might help, and of course any patient who has a compromised airway, put him on the highest flow oxygen you have available in your ward. If the airway is patent, you don't have any issues with it, then you will move to the next step, which is assessing the breathing. Have a quick look, assess the rate, pattern, and depth of breathing. Assess the patient in general if he looks in respiratory distress and using his accessory muscles. As you can see in the short video above, this is a sign of a patient who is in respiratory distress and impending fatigue and tiring, and shortly he will be hypoventilating and deteriorates more. Check the oxygen saturation, examine the chest, auscultate the lungs if there is any add sounds or if there is any asymmetry in the chest movement. Check the trachea if it is central, because it can be a sign of a big pneumothorax or a massive lung collapse. The management for a patient who's having a breathing problem, these are simple measures that you can start with. Position the patient in upright in bed. This will ease the pressure on the diaphragm. As everybody knows that the most important muscles of breathing are the diaphragm and the intercostal muscles. If the patient is lying flat, the whole abdominal content will be splinting the diaphragm, preventing it from fully expanding the lungs. When you set the patient upright in bed, you will ease the pressure on the diaphragm, giving more room for the lungs to inflate, and this may solve the problem altogether and improve the oxygenation. And as I said earlier, put the patient on high flow oxygen, treat the abnormalities that you have discovered in your examination, and you can take a blood gas to identify which type of breathing problem you are dealing with. If the patient has a respiratory problem, so in terms, this is called a respiratory failure, and we will talk about the definition about it shortly. So as we said, the respiratory system, the main function of it is the gas exchange between the environment and the body, which will facilitate the aerobic metabolism. The respiratory system will provide oxygen to the body and also will remove carbon dioxide from the lungs. So these are the two main functions of it. Any defect in any one of them, this is a failure. And according to this, they have categorized the respiratory failure into main two types. And these two types can be acute or chronic as well. These are a few pathophysiological considerations about the gases that we are dealing with at the moment, mainly oxygen and carbon dioxide. If you understand these few points, it can help you easily understand the types of respiratory failure and how you can target your management based on the defect. So CO2 is more water soluble than oxygen. So what does it mean? It means that the movement of carbon dioxide through tissues is 20 times faster than oxygen. And that's why most of the pathologies that you will face will start with type 1 respiratory failure. Even the COPD, which is known to cause CO2 retention, in the early stages of COPD, it's type 1 respiratory failure. The oxygen is less water soluble. It needs specific parameters optimized to move from the atmosphere into the body. These parameters are mainly as you can see in the third point, is the amount of oxygen that inspired is really important. And once it reaches to the alveoli, it needs a healthy alveolar capillary membrane to move across, and it needs a huge surface area to facilitate that. If you know that the surface area of the alveolar capillary membrane in an average adult is around 140 square meters, which is a huge space. It's like a flat size. Any defect in this surface area will compromise the oxygen transport. And also, because it's less water soluble, it needs more time at the interface to move across the membrane. But the CO2 is much nicer gas, and it just needs less amount of the surface area, less amount of time, and it will just diffuse easily through from the blood to the alveoli. But it still needs clearing from the alveoli, which we called a ventilation. So the air in the alveoli needs to be renewing by inhalation of a new one, exhalation of the old one. The defect is in the ventilation that will cause the retention of the CO2. So based on this criteria, the criteria of the oxygen and the carbon dioxide, they have classified the respiratory failure into type 1 and type 2. So the type 1 will mainly be due to affected oxygenation. So the oxygen is not getting into the blood. And when you measure it by a blood gas, you will find a partial pressure of oxygen of less than 8 kilopascal or 60 millimeter mercury. There are a wide variety of causes that can lead to type 1 respiratory failure, but I've tried to summarize them in 4 main categories. If we take it from outside inwards, so if you have low atmospheric pressure or low FiO2 in the atmospheric pressure, like in high altitude, this can cause type 1 respiratory failure. If you have defect in the diffusion, like the alveolar capillary membrane has a defect, like if it's destroyed by an emphysema or it's fibrosed in interstitial lung disease, this will cause type 1 respiratory failure. If you had a look on this picture, you will understand the VQ mismatch and the right to left shunt. So I'm not sure if you can see my cursor, but this alveoli in the right upper lung is well ventilated, but you can see any blood going through. And on the lower right base, you can see a collapsed alveoli. It's well perfused. So overall, this right lung has a VQ mismatch. The ventilation and the perfusion are not matching at all. And this can happen by a pulmonary embolism, heart failure, COPD, ARDS, and so much other variety of causes. Right to left shunt is just the deoxygenated blood bypasses the lung at all and doesn't get in contact with the alveoli. Like if there is heavy malformation, if the alveoli are collapsed and atelectatic or filled with pus like in pneumonia or fluid like in pulmonary edema, or if the whole lung is just compressed by air from outside and it's whole collapsed and not ventilated at all. So all these causes can lead to type 1 respiratory failure. Treatment of type 1 respiratory failure, these are the broad lines of the management. Each one of them needs many lectures to explain, but it's again like a stepwise approach. First, you identified the pathology, treat it, support the patient with oxygen therapy because it's the easiest thing to correct at the time being. If you remembered, I've explained the 3 main things that oxygen needs: the FiO2 and the surface area and the transit time. So the easiest thing is to correct is increase the FiO2 to optimize the oxygen delivery, and we will speak about it in details shortly. If the oxygen did not improve with oxygen therapy, move to the next step, which is the CPAP, and we will explain it shortly as well. If it fails, the next step will be invasive ventilation, and again, if it's failed, there is an extracorporeal oxygenation, which is like a dialysis machine. It will take blood from the patient, oxygenate it, and return it back to the body. Type 2 respiratory failure shares the same thing with type 1, which is hypoxia. The partial pressure of oxygen is less than 8, but the CO2 also is now compromised. And I also take it as it's more advanced stage or more severe state, more than type 1, especially if it is a chronic one. Because as I said earlier, CO2 is a very nice gas. It's just diffuse easily from blood to the alveoli. But if the lung is severely affected, that even the CO2 is not going across the membrane, that means it's severely damaged. Unless it's something is not related to the lung itself. Like if you look at the causes there, the first thing is the what's called respiratory pump failure. So the lung is not exchanging air as it should be, and the problem is not in the lung itself. It's either in the central drive, the CNS disorder, like in stroke and coma, and the patient is not ventilating well, or if he's under the effect of any drugs like morphine. If there is a neuromuscular problem like GPS, myasthenia gravis, or spinal cord injury, or if there is a problem with the chest wall and the pleural disorder like massive effusion or flail chest. The other cause of type 2 respiratory failure is increased dead space. The dead space is a part of the lung that is filled with air, but it's not sharing in the respiration, so it's not getting in contact with the blood. Like in COPD, big part of the lung will be emphysematous, destroyed, inflamed, and filled with air, but it's not doing any benefit. The last cause is not a direct cause of type 2 respiratory failure, it's just the increased production in comparison to the clearance. So increased production alone is very unlikely to cause type 2 respiratory failure, and the body can easily compensate for that. But if the compensatory mechanisms are defective, this can lead to type 2 respiratory failure. The management for type 2 respiratory failure, again, you will start with treating the cause and giving the patient oxygen because he will be hypoxic as well. And then the next step will be improving the ventilation with non-invasive ventilation, NIV, which we will explain shortly. If it fails again, the next step will be invasive ventilation if the patient is a candidate for, and even if the invasive ventilation failed, you can use another extracorporeal machines like extracorporeal carbon dioxide removal. Now I will talk about the different devices that you can use in oxygen therapy, how to choose between them, what's the difference between them. They are simple devices that everybody sees, everybody's seeing them and every day in the walls, but they have slight difference, and also understanding the process of oxygen support is really important. It can help you to identify why the patient is not responding to the oxygen that you are giving. So we will use oxygen therapy for the patients who are hypoxic but still self-ventilating. And as I said earlier, this is the first step, and the easiest step to correct is increasing the inspired oxygen, hoping that this will improve the hypoxia. Most of the devices that we use in the wards have low flow rates. And what does it mean? If you think about the normal flow rate that the normal subject use at rest, it's ranging from 25 to 35 liters per minute. it's not the amount of air that the person uses, it's the speed of flow from the atmospheric air down to the alveoli. So the air travels with a flow of 25 to 35 liters per minute in a normal subject in a resting state. In critical illness, then this can increase like 8-fold and goes up to 200 liters per minute. This is the patient demand of air in critical state. This simple oxygen devices that we use on the ward, and I think everybody will remember the number. The maximum flow rate that you can use in the ward is just 15 liters per minute. So if the patient is critically ill and his demand is 20 liters, and you're providing him with oxygen of 15 liters per minute, which is less than 10% of his needs, from where the rest will come? It's basically will come from air around the device that you are using. So the oxygen that you are giving, even if it's 100% oxygen, it will get diluted with the air that the patient will inhale to compensate for his demand. So that's why the limitation of using these oxygen devices has two different factors with the patient himself and factors with the device. The patient, as we said, his inspiratory flow rate is very, very important because you have to match the demand. If the patient doesn't have a respiratory pause, it's in normal breathing. After inspiration, there will be a pause. This will give time for the oxygen to go through the membranes to the blood. If the patient is so tachypnic and in respiratory distress, it's usually this respiratory pause will be absent. And the amount of air that the patient inhales, which is the tidal volume, also if the patient is tachypnic, he will have a shallow breathing and the tidal volume will be very, very less. The factors that in the device, and again, it's the flow rate of the device that you use, the volume of the mask itself, because it will act as a reservoir of that oxygen, and the size of the vent that the oxygen goes through, and how tight is that device on the patient. The oxygen delivery devices that are used are categorized into 4 main categories. One with a variable performance, and it means that the amount of oxygen that you give to the patient is variable and depends on so many things. And you have a fixed performance system that you can be sure about the amount of oxygen that you are giving to the patient. And you have devices with a high flow system, and there is other devices as well, like the extracorporeal one we spoke about. All these devices will share on the component parts of it. It needs an oxygen supply. There will be a flow meter attached to it. There will be connecting tubes from the oxygen source to the patient. They will have some sort of a reservoir, and of course there will be a port attached to the patient. There will be some sort of a mechanism of allowing the expired gas to be eliminated. There will be some sort of humidification, and sometimes you can have oxygen monitor on it. I will start with the variable performance systems. They are very common, everybody knows them. The first one is the nasal cannula, and I've listed again the components to understand how this device works and what its limitation. So you can connect it to the oxygen source on the wall or a pressurized cylinder, and on the down right picture you can see the flow meter, and you can adjust how much the flow. And again, think about the flow. It's not the amount that you give to the patient, it's the speed of gas traveling through the connecting tubes. So the maximum that this nasal cannula can tolerate, the flow I mean, is 2 to 4 liters per minute, which is very less. That's why it's used with more stable patients who have mild hypoxia. You can see the connecting tubes for the nasal cannula are very narrow. That's why they don't tolerate higher flow rates. The reservoir of this device will be the nasopharynx, and it has a very big disadvantage that it is very sensitive to the patient inspiratory flow rate. So if the patient is tachypnic and breathing hard, he will wash out all the oxygen that you are hoping to build inside the nasopharynx, and he wouldn't get any benefit from the nasal cannula. The patient attachment is simple, and it's one of the advantage of it. It's easy tolerated by the patients. The expired gas, you don't have to worry about accumulating the carbon dioxide because it's just connected to the atmospheric air. There is no humidification on the nasal cannula, which is one of the disadvantages and can cause nasal dryness. It's just use the physiological humidification system from the nasal mucosa, and you don't have an oxygen monitor attached to it. So the advantage is it's cheap, simple. Anybody can easily use it with the patients. There is no risk of CO2 retention, and it's well tolerated by the patient. But it has an oxygen reservoir which is very sensitive to the patient flow rate, and the patient can easily wash out the whole oxygen that you are giving to him, and it can cause nasal dryness, especially if you try to use high flow rates with it. Any questions so far? I know it's a very boring subject, but I'm trying to simplify it as much as I can.
So far, so good. Carry on.
Okay, the next device in the variable performance system is the simple face mask, and it's very similar to the nasal cannula. The difference are that you can use higher flow rate with this device, can go up till 15 liters per minute, and it has again the whole components. The reservoir in this device is different. The mask itself, you can see there is some space between the patient face and the mask. This can hold some oxygen in it and work as a reservoir, and also you can attach a reservoir bag and to it, and it will help as an extra space. The patient attachment again is well tolerated by the patient and simple to use. The expired gas will go through small holes. You can see it on the sides of the face mask, and this mask also can be turned into a non-rebreathe system. So these holes can have a valve on it, which will be a one-way system. It will allow the exhaled air to go out, but it won't allow the patient to rebreathe it again. The humidification, it can either be a physiological one, or it can be attached to a humidifier, as you can see in the picture below. And this humidifier can have an oxygen monitor on it, so you can adjust how much FI2 exactly you want to give the patient. The advantage again is it's cheap, easy to use, and well tolerated, but the main disadvantage of it can cause CO2 retention if the flow is not matching the patient demand. Now we will move to the fixed performance system, which is the Venturi masks. The difference between Venturi and the simple mask is it has a valve in it. It uses the Venturi principle. It's basically the pressure of the flowing gas will entrain air with it, and it will add to the flow rate. So the flow rate in this mask will be higher than the simple face mask or the nasal cannula, because it uses air with it, and it's controlled. So in every single valve, it will be mentioned on it how many liters you should give, and with these liters, how much exactly the FI2 that will reach the patient. And again, it's also cheap and easy to use, well tolerated, and has more advantage of predictable FI2, and it can give higher flow rate. So you wouldn't be worrying that if the patient is tachypnic, it will wash out that oxygen that you are giving. But the main disadvantage of this device is once you increase the flow, it will have to compromise the oxygen, because more air will be entrained into it, and the oxygen will be more diluted, and then the FI2 will drop. Now to the high flow systems, like the high flow nasal cannula. It was originally developed with neonates and pediatrics, and then recently has been moved to adults, or we can say it's not recently anymore. It has the same components and like the other devices, the oxygen source and the tubing, humidifier, the reservoir and the patient interface. So the main advantages of this device that it gives a very, very high flow rate, can go up till 60 liter per minute. And with this very high flow rate, it's well tolerated because the air goes through a humidifier and it will be a warm air, so the patient will tolerate this much better. With this high flow rate, it can give some sort of a pressure splinting the airway, and also can wash any carbon dioxide from that airway. And these two factors can decrease the work of breathing for the patient. But unfortunately, these devices are only available in high dependency unit and needs trained staff to deal with it. The next step in the respiratory support, if you have exhausted all the means of oxygen delivery and the patient is still deteriorating, this will be the time to think about a ventilatory support. The ventilatory support is a very, very big and wide subject and have so many types and varieties in it. It's really out of the scope of this lecture, but I've just picked up the two most common modes that mainly used outside the intensive care, how to use them, what are the indications and contraindications, and what are the settings, just to have an idea about them. Briefly about the ventilatory support. Normally we breathe a negative pressure ventilation, so the pressure outside the lungs in the atmospheric pressure is higher than the pressure inside the chest, and the lungs, it just sucks air inside. This is a negative pressure ventilation. When we give the support, we will turn this ventilation into positive pressure one. So we will give much, much higher pressure from outside, increasing the pressure inside the lung, trying to open the collapsed parts of it, or pushing the air through the capillary, alveolar capillary membrane. And this ventilatory support, the positive pressure ventilation, can be either invasive by endotracheal tube or tracheostomy, or can be non-invasive by a mask or a helmet, and it can be used as a curative for respiratory support, or a protective for the airway and the lungs. I'm going to speak about the non-invasive part of it, and specifically about the CPAP and NIV, because they are the most common ones that being used in the wards. So the non-invasive ventilation now is like a standard of care, especially for COPD patients. And when they started to apply it, the studies has shown that it really decreased the need of invasive mechanical ventilation, with all complications happening with it, and also shortens the length of stay for a patient in hospital. So I know this might be confusing about the CPAP or NIV. What does it mean? What's the difference? They look like the same, but there is there is a slight difference, but it's really a unique in each part of them. So first of all, they are not overlapping, and they have different indication of use and different mechanism and physiology as well. The CPAP, the definition of CPAP is a continuous positive airway pressure. As I have said earlier, the normal breathing is a negative pressure, and when we try to support the breathing, we will give positive pressure from outside. So this pressure will be a continuous positive pressure throughout the whole breathing cycle, inspiration and expiration. If you want to imagine it, like have a feeling of going in a car in a high speed, open the window and get your head out of the window and try to inhale that very high flow air going through your lung. This is a continuous positive pressure throughout inspiration and expiration. Some authors don't involve this support as part of a ventilatory support because the pressure given is mainly driven by the high flow. It's not really a pressure, and it's only splinting the alveoli and the airway opens. But the CPAP can allow you to give very high flow to the patient with very high FiO2, and it can be given either by a tight mask over the face or nose and mouth, or with this helmet in the picture, as you can see. So what's the NIV then? The NIV stands for non-invasive ventilation. And again, it's one of the respiratory support using a positive pressure, but it has two different pressures or two different levels of pressure. The inspiratory pressure and the expiratory pressure. The inspiratory pressure will be higher than the expiratory one, and the difference in that pressure will drive the increase in the ventilation. So the inspiratory pressure will support the ventilation, and the expiratory pressure at the end of the expiration will keep the alveoli patent and ready for the next cycle to start. So what are the indications for each of these? The CPAP is mainly to improve the oxygenation. It doesn't support the ventilation much. So you have a patient who is hypoxic, but he's still breathing, and he's still able to maintain his own breathing. You can give him some sort of high flow with a pressure with it to just give him a comfort and reduce the work of breathing. As a patient who has severe pneumonia, you can start CPAP initially. It's either a bridging before invasive ventilation and see if it works. You can reduce the need of invasive ventilation, or it might be as a sealing of care. In pulmonary edema as well, the alveoli is filled with fluid. It just needs a bit of pressure to push this fluid back into the intravascular space and keep the alveoli open. And in obstructive sleep apnea, this is a protective indication. It just keeps the airway open when the patient is asleep. In chest wall trauma as well, this can help, like if you have a flail segment, but you have to exclude pneumothorax before using it. For the NIV, the most common indication is COPD with respiratory acidosis, or type 2 respiratory failure secondary to chest wall deformity or a neuromuscular disease, and also can be used to enhance the weaning of the patient from invasive mechanical ventilation. All these indication is like we will assume that the optimal medical management has been already used and failed. what are the contraindications of CPAP and NIV? They need a patient who still can protect his airway. So if the patient is vomiting or has excessive secretion, this is not suitable for him. If the patient is so confused and agitated and has an impending risk of losing his airway at any time, again, the non-invasive measures will not be suitable for him. If the patient has very low GCS or has facial burns and trauma, or he has a pneumothorax which is not drained yet, these are contraindication of using CPAP or NIV, unless it's like ceiling of care or a bridging until the invasive mechanical ventilation is ready. This is like a general idea about how to use these different modules of ventilatory support. Using the CPAP, as I said earlier, you can use a tight mask or a hood. So you have to choose the appropriate side for the patient and ensure that the device is good, has a good seal and not leaking. Usually you will start with a CPAP of 7.5 and FiO2 of 100%, and then you can titrate them down as per patient response. The maximum PEEP that we have been using is mostly 12 centimeter water, because we have noticed more than that it will be uncomfortable for the patient and the system will start to leak as well. Monitor the patient with saturation and blood gases. Usually, if the patient has an oxygenation problem, the target for your oxygen saturation will be 94 and above. The NIV, as I said, you have two different levels of pressures, the inspiratory pressure and the expiratory pressure. We usually start with 10 centimeter water for the inspiratory pressure and 5 for the expiratory one, and observe the patient for the response. If the patient is still hypoxic, you will increase the expiratory pressure, and you can increase the FiO2 as well. If the carbon dioxide is not cleared enough, you can increase the inspiratory pressure. The maximum inspiratory pressure tolerated by this support is 25 centimeter water. And again, you will monitor the patient for the response, GCS, saturation and blood gas, and be ready to move to the next step with invasive ventilation if the patient is candidate for. The complications of using a positive pressure ventilation is that it increases the intrathoracic pressure, which can give more load over the heart and reduce the venous return and can compromise the cardiac output. It can also cause stomach inflation, which is a very high risk of aspiration. It can cause air leakage from the lungs or the mediastinum and cause pneumothorax and pneumomediastinum. High inspiratory pressure can reduce the patient tolerance, and also the very tight mask on the face is very easily causing pressure sores. Now I'm coming to the end of our lecture today with a brief summary. We talked about how to assess an acutely ill patient using the A to E approach, identifying the problems and treating them before moving to the next step. We have given an idea about how to identify a patient with airway problem and breathing problem and how to approach them. I've spoken about the different types of respiratory failure, the causes, and how to manage different devices that can be used in oxygen therapy, the limitation of each, and the advantages and disadvantages, and a brief idea about the ventilatory support, and specifically about the non-invasive ventilation, different types, and what are the indication and complications of these. Any questions for all this loads of information that you have heard?
Thank you very much, Dr. Mohsen. It is a tough subject, actually. A flow of information, a flow of lot of information, high flow of information. Yeah,
Yeah,
it is
true.
but
And it's
thank
very
you.
boring information, I know as well.
It's high flow, high pressure.
Yeah, it's mainly the physics of gases is really important to understand these devices and how to use it, what are the indication, contraindication. And I've seen that we've been using all these devices for so many years, and we don't know much about these fine details. But it's really important. It helps you to decide. At least it will help you to predict if I'm using this device, what to expect for the patient response, at least. Mahmoud, yeah?
Mahmoud had a question, yeah.
Thank you, Mohsen, for this lecture, actually. But can you just go back to the indications of non-invasive ventilation and CPAP and the difference between both of them?
Can you still see my my screen?
Yeah, it's still there.
Yeah, this one.
Oh yeah, that's right. Okay, so in cardiogenic pulmonary edema, it is CPAP and not non-invasive ventilation.
Yeah, CPAP is mainly to improve the patient oxygenation, and it will help slightly in the work of breathing, but it's not the main idea of it. The main idea is just to give the patient more oxygen with a very high flow, and this high flow will give a bit of a pressure. But the main aim of CPAP is just a flow of air. But for NIV, it's mainly to correct the hypoventilation. You need more air going in and coming out of the lung to wash out the CO2 and improve the hypoxia as well. For pulmonary edema, the main pathology is not in the ventilation. The patient can breathe, the air can go in and out, but the problem is the alveoli itself is filled with fluid. So they will use the high flow with a bit of a pressure coming from this high flow to inflate the alveoli, pushing this fluid back to the intravascular space and improve the oxygenation. If you give an inspiratory pressure on top, it won't make difference because the patient is already ventilating well. Did you get it?
Yeah, I think so. Yeah, great, thank you.
A question, a technical question, if you don't mind, Dr. Mohsen.
Yeah.
It is the same device used for CPAP, used for just changing the setting to make it a non-invasive ventilation or a CPAP machine. Is it right?
No, the CPAP has the same components like the simple oxygen devices. So the oxygen source will be a flow meter, but this flow meter can give very high flow. And the mask that you will use for the CPAP can be used in an NIV, but
Yes.
the device itself is different.
Yeah.
Okay. The hood that in this picture, this used only for CPAP because the high flow will go inside this hood, and it will be it will make some sort of a pressure. And if you can see this valve, the yellow one,
This
this
picture is
one,
strange for me, actually. I always see the mask for CPAP, and I believe it is also used in the non-invasive ventilation. I saw that the same machine delivering the high flow can deliver also the ventilation pressure airflow.
yeah, you can use the same machine that has the ability to give NIV and switch the setting to CPAP. But if you have a CPAP machine, it just gives CPAP because it's just a flow meter. It doesn't have any other modes. And also the confusion comes from there are machines that made to be used at home and machines that are used to be in hospital. So there are so many brands and companies are making so many changes. So there might be somewhere there a machine that can give CPAP and NIV. But I mean, the mechanism is different.
Yeah, I understand.
Yeah.
Any other questions? Okay, thank you very much, Dr. Mohsen. It was very interesting subject. You did very well, give us a lot of informations. At least we know the basics. It was very long lecture that have a long and variety of informations, but at least our background with the basics of the dynamics of air, and so at least we get some basics information that can help us with understanding these machines that we at any time we need them in during the daily practice. Thank you very much, and see you in next lectures.
Thank you, everybody, and I will put these slides on the group as well. If anybody has any question, feel free to send me a text. And thank you, everybody, for attending, and see you next week, inshallah.
Thank you very much, everybody.
Thank you. Thank you. Assalamu alaikum.
Thank you, everybody.